actively discuss the findings and let me know. I will correct those things. Okay, and that will be fine. Is that okay, Devapriyo? Is that the way we have to discuss? Yeah, yeah. Fine, fine. See, whatever it is, be it DNB or MD, your final year long case is going to be neurology only. So that is going to determine your fate, whether you will pass or fail the examination. So once you are very well done with your long case and you create an impression to the examiner that you have presented well, your history is good and your examination findings are good, then you are done. Like you are half the way, more than half the way you clear that exam, you can take it. So for that, you need to know a basic history taking, clinical examination, okay, and a structured approach is needed for neurology. Unlike other systems, no, that maybe appear very simple, but neurology is a very long system starting from general examination, higher mental functions. You have to look for cranial nerves, motor system examination, sensory, reflex, cerebellum, gait, everything you have to check in detail, and then you have to make a meticulous note out of it. So it may be a time consuming thing also. So unless otherwise you practice it, unless otherwise you do right before the exams, some 5 to 10 times by yourself, it may be difficult and you will not be able to complete the scheme of examination also. Okay. So the first and foremost thing is to like practice before you go for exams. So in general, I'm basically I'm from South. I'll tell you what are the cases that may be kept in examinations for long case, especially in MD. For UG, you all know, unless otherwise proved, it is going to be what case? Hemiplegia, right? For MD, it may be different. So you may get long cases like spinal cord syndromes, compressive versus non-compressive myelopathy. Then you can get motor neuron disease. You can get if an institute or a HOD wants to decide, he can keep ataxia cases also. There can be cases for peripheral neuropathy and muscular muscle disease like muscular dystrophy or proximal myopathy, something like that. They can be kept. Okay, it's rare to keep stroke, but if that all they are keeping stroke, it may be a complex brainstem syndromes like that they will keep for MD level, not at the level of mm, like hemiplegia. Straight away, hemiplegia will not be there. Okay, so at least be prepared with these long cases. Take notes and keep. Read the clinical findings, read the examination techniques, examine on the patients, and basics should be thorough. Nobody is going to ask you so many things, or like nobody is going to threaten you by asking, tell me that syndrome, tell me this syndrome, what is this, what is that. It's basically going to be a structured approach. How are you going to take the case, and how is your basic knowledge and demonstration skills? Okay, if you develop that, that's fine. Not more than that, it's going to be asked in the exams. Okay, okay, fine. Short cases are usually CNS, CVS, or GIT only will be there. Long cases are neurology. In some stations, you can heap only motor system examination or examination of reflexes like a stations can be kept in OSCE. So that if you are thorough with the long case examination, that also you can get through. It will not be a big issue for that. Okay. Okay. I think this would be sufficient, right? Okay. Is
The
that PG available here? Yeah, okay.
yes.
By looking at the picture, what's your spot diagnosis, doctor?
Spot diagnosis is a Bell's palsy.
Hmm.
Uh, left side eye is not closing, so left-sided Bell's palsy.
Very good. So this is a common spotter that will be kept. Okay, this is Bell's palsy. What type of facial palsy is this? I mean, what is the type? Whether it is a human facial palsy or an LML facial palsy?
LMN.
Element facial palsy since
LMN facial palsy. So you
yes,
should be knowing the difference between UMN and LML facial palsy, right? So why do you
yes,
call it as LMN facial palsy?
the
Okay. The basic is if it is UMN, only the lower half of the face will be
lower half.
affected. In LMN, both upper as well as lower half of the face is affected. Okay. One of the classical or telltale finding to tell it as an LMN facial palsy is presence of dash phenomenon.
Okay.
Presence of which phenomenon?
Mm,
Bell's phenomenon. Have you heard of this Bell's phenomenon?
mm, no, sir.
Bell's phenomenon, did you know? You might be come across this no Bell's phenomenon. When there is an element facial palsy, on attempted closure of eye, you will see there is an upward movement or rolling of the eye, and
Yes.
the eyelid is not possible, not able to close completely the affected side. So you can visually see this phenomenon that is happening. Normally it happens otherwise also. Okay, the upward movement or rolling of eyeball. You try to close your eye, you can feel that the eyeballs are moving upward. But when there is a what you called this eyelid is not able to close properly because of facial palsy, that movement of the eyeball you can see it very clearly, and that is called as Bell's phenomenon. Okay, so the difference between a UMN and LMN facial palsy is that UMN facial palsy is confined only to lower half of the face, and UMN facial
Yes.
palsy and LMN facial palsy is confined both to upper as well as lower half. For MD level, that is sufficient. Okay. Mm. And always the deviation of angle of mouth is towards
Normal side.
to the opposite side of the normal side. Okay. What are the other findings you see? Can you just describe the findings in this?
The left eyelid is not closing, and the deviation of mouth is on the right side.
Acha, fine. So basically, this is called, what is it called? When attempted closing of the eye, the lid has to completely close. There is a lid lack, then,
Yes.
and the nasolabial
Uploading.
fold on the affected side is flattened. Between the nose and the cheek muscles, no, you have some fold called that is called as
Labial.
nasolabial fold between the lips, nose, and the upper cheek aspect. So there you have a fold. That fold is becoming flattened over here. So flattening of the nasolabial fold. There will be deviation of angle of mouth towards one side. Okay, that will be the opposite side. So these are the common other spot findings that you can observe while seeing the patient. Otherwise, then you will be asked to test for the patient. Like, how will you test means you should test for both sensory as well as motor. Okay, for motor you have many tests like closing the eyelid, whistling, some of the facial expressions you can check, and sensory you can check for taste sensation over the anterior two-third of the tongue. Okay. Taste sensation over the anterior two-third of the tongue. That is supplied by which nerve?
Um, uh, okay.
Chorda tympani branch of facial nerve. Have you heard of this chorda
Yes,
tympani
yes.
branch? So that is supplied by chorda tympani branch of the facial nerve. Okay. So that is what about sensory taste sensation. And for motor, you have to check for closure of eyelids, and whistling, and ability to keep the air inside the mouth. Okay, so that and all you should check properly. Hmm. Now coming to the etiology wise, um,
Um,
so what is the most common
but,
cause for Bell's palsy? That is the element facial palsy.
uh, it is said idiopathic, but there is a viral cause.
It's usually idiopathic, but there is a virus cause. Somebody will
Yes.
say that in a diabetic it is more common, some viral infection is used to happen. Okay, so do you know any named syndromes with associated with Bell's palsy or element facial palsy?
Uh, uh, Herpes zoster virus infection.
Okay, when herpes zoster virus infection, secondary to that, if facial palsy is coming, that is what called. What is the name of the syndrome?
Ramsay Hunt syndrome.
Very good. That is called Ramsay-Hunt syndrome. Okay. Then, any other syndrome with some abnormality over the tongue? I think few people are raising their hands. Should I ask them, or Yeah, Sarathi or Sonam can tell.
They have written in chat box Fisher's tongue.
Fissures in the tongue. What is that syndrome called? See, when LM and facial palsy comes, no, these are the questions that are going to appear for you. You should be knowing about this. So you can note it down. What are the difference between LMN and UMN facial palsy? Why do you call it as LMN facial palsy? What is the characteristic finding you see? That is the Bell's phenomenon. When they are telling to explain Bell's phenomenon, you should tell what is the common cause of LMN facial palsy. One is idiopathic, otherwise it is most commonly viral infection, especially in a chronic uncontrolled diabetic patients. Okay, then what are the named syndromes? One you have told that Ramsay-Hunt syndrome. The other one,
Yeah.
So, yes, sir. Melkerson-Rosenthal syndrome, sir.
very good. Melkerson-Rosenthal syndrome. They have an abnormality, fissured
Fissure tongue, yes.
tongue will be there. Okay. So now, one of the most important questions for MD level is the not only unilateral facial palsy. Sometimes there may be cases of bilateral element type of facial palsy can happen. So can someone tell some of the causes for bilateral facial palsy?
Oh, sir, can I go? Can I answer?
Yeah, yeah, you can
Lyme
answer.
disease,
Whoever knows can
Lyme
answer.
disease, infective Lyme disease.
Good, Lyme's disease, but how frequently are you coming across Lyme's disease in India by?
None. Zero.
Uh,
GBS, multiple sclerosis,
very good. GBS,
sarcoid,
sarcoidosis,
uh, diphtheria, but it is not very common.
diphtheria, facial palsy is
Why?
okay. GBS I accept. Sarcoidosis I accept. Then
Multiple sclerosis.
multiple sclerosis, facial palsy, bilateral. Okay, rarely, but you should keep it down. Those demyelination causes and all. There are some classic. These are classical questions. You will be GBS, sarcoidosis. What is uveo parotid fever or heat fort syndrome?
In Sjogren's.
That is in Sjogren's or in sarcoid?
Sorry, sarcoid.
Sarcoid. That's in sarcoid. They can also have
Right.
bilateral facial palsy. Then, which other infection can affect all systems known?
Actually,
Infection I told. HIV. HIV can have bilateral facial palsy also. Okay. Then, as he said, Lyme's disease. Okay. And some examiners will be wanting to see whether you are able to tell this or not because there are some muscular causes which causes bilateral facial palsy. What are those?
Myasthenia,
Myasthenia, facial palsy. No, unlikely.
facioscapulohumeral dystrophy.
Very good. Facioscapulohumeral dystrophy. Very good.
Sir, in case of dystrophic myotonia,
Excellent. Myotonic dystrophy or dystrophic myotonia. Very good. Very good. Okay. Then neuromuscular junction. It's not myasthenia, but
Lambert-Eaton.
no. Sometimes in botulism and an acquired neuromuscular function defect, bilateral facial palsy. Some very rare old examiners will expect this pass. Snake bite. Okay. So in snake bite, what happens? Neuromuscular transmission is affected, right? So they can have with bilateral facial palsy also. Okay. Now I have told few causes. List out the same. Sonam can list out it. Whatever I have told.
Yes, sir. GBS,
Yes.
Lyme, sarcoid,
Sarcoidosis.
multiple sclerosis,
Which poisoning?
snake poisoning,
Snake
snake
is not
bite.
called poisoning. My
Sorry,
God.
snake bite.
Snake bite. Then muscular causes you only told, no?
Yes, sir, yes, sir. Facioscapulohumeral dystrophy, myotonic dystrophy,
Yes. HIV.
HIV.
HIV, and diphtheria. Yes.
Diphtheria, see, diphtheria and multiple sclerosis, don't bring it in the front. Okay. I have already
Okay.
told some 5 or 6 causes. You have to tell that only.
Okay.
GBS, sarcoidosis or uveo parotid fever, HIV, okay, Lyme's disease, and snake bite related, facioscapulohumeral. Please mute yourself. Someone is talking. HIV, FSHD, that is facioscapulohumeral dystrophy, and myotonic dystrophy. Fine.
Yes, sir.
So the next question will be like the anatomy. You have to trace out the facial nerve from the origin and till the end. Okay. And where's the facial nerve nucleus located? Which part of brainstem?
Pons.
Pons. Situated near which nerve?
Sixth nerve.
Sixth
Facial
nerve.
colliculus.
Facial colliculus. Very good. Very good. Is it possible to trace if somebody has read about facial nerve course? Is it possible to trace the facial nerve?
So I can try.
Yeah, you can.
It begins in the pons, takes a curve around the sixth nerve nucleus, forming a facial colliculus. Then travels out through the petrous part of the temporal bone, and then enters into the internal acoustic meatus along with the eighth nerve, and then the sensory and the sympathetic part known as the nerve of Risberg. Then it enters into the internal auditory canal, gives out a branch called as greater petrosal nerve, which then goes through the pterygopalatine ganglion and forms and together with deeper petrosal nerve, which is given through the internal carotid artery, it forms the canal of I forgot what it forms, and it supplies the lacrimal glands. Then the other part goes into the medial part of the ear, middle canal, gives out the chorda tympani branch, and the
Where is the chorda tympani? But chorda tympani branch is inside the middle ear or outside the middle ear?
so right
It's
after it
outside.
gives the greater petrosal nerve, it gives the okay.
Right after it gives the greater petrosal nerve, it enters into the middle ear. I mean, it enters into the inner ear, then it takes a turn in the middle ear through the internal genu of the facial nerve, and then it comes out of the middle ear, reaches the stylomastoid foramen, just 6 centimeter or like 6 centimeter above the stylomastoid foramen. It gives up the branch called chorda tympani branch of the facial nerve. Okay, chorda tympani branch is responsible for the taste sensation. And when it leaves the stylomastoid foramen, it comes near the parotid gland. It lies underneath the parotid gland and gives up distal 5 branches. So tell me, what are the distal 5 branches?
So so temporal, zygomatic, mandibular, cervical, and buccinator.
Buccinator is a muscle.
So
Nerve you.
nerve.
Buccinator is a
Distal
muscle,
branch.
Baba. What nerve? Temporal. You can keep like
Tem-
arched, like your fingers, 5 fingers, you can keep on the face and then you can accordingly tell. Temporal, zygomatic, buccal. Okay.
Buccal. Okay.
Upper buccal and lower buccal. Then
Then cervical,
Mandibular.
mandibular,
mandibular and
Mandibular.
cervical.
cervical. Mandibular and cervical. Okay, fine, fine. Facial nerve testing and all you should see on the patient's bedside. Okay. Otherwise, this is okay, I think, for this facial nerve question. Let's move on to the next question. Well done, Dr. Harin and Dr. Sana. Okay. Harin, you should read little bit more on facial nerve. Okay.
Yes. Yes.
Okay. What is his name? Sarthik Kumar. Bacha has gone into daydreaming, I think. That's okay. Anybody else can try, otherwise, I'll just. I can see them, Arya Mahapatra.
Yes, sir, I'm here. Yes, sir.
Okay, let's go. Arya, what is this being displayed there?
Sir, this is the lumbar puncture needle.
Very good. This is LP needle. Why there are multiple length and multiple colors are there?
Sir, multiple colors depending on the bore size and
What you call
multiple
it?
length.
Gauge. Gauge.
But,
Gauge. So is it possible to remember the size of the needle by you? I know it is
no, sir.
difficult only. Most of the times we also will order by colors only. So it is difficult to remember. But for exam purpose, you can just remember. Commonly used only I will tell you. Okay. Black is the commonly used, that is 22 gauge. Okay. Green is 21 gauge. Yellow is 20 gauge. You know, right? When the gauge size increases, the bore of the needle is very small. When the gauge size
Small.
decreases, the bore of the needle is going to be wider. Okay.
Yes, sir.
Okay. Some when this LP needle is being kept, the common questions are going to be, what are the indications of using LP needle?
For the CSF study during diagnosis of the acute meningitis,
Diagnosis of
causes of that,
meningitis. True.
uh, then for the LP in case of if TB meningitis is there, then TB or viral or bacterial.
Baba, meningitis. You told in meningitis you do CSF analysis. Fine. Next.
Another maybe in case of GB syndrome, we can show the albuminocytological dissociation.
Albuminocytological dissociation for CSF analysis in GBS. Very good. Then,
Um,
be it
then
any
in case,
inflammatory or demyelination condition, you should do CSF to look for intrathecal protein synthesis or intrathecal antibodies, anything is synthesized or not.
yes,
Finally,
sir.
LP needle is also given for spinal anesthesia, no?
Spinal
Yes,
anesthesia,
it
yes,
is.
sir.
Spinal anesthesia. Then LP needle can also be used for injecting dyes in case of myelography in olden days. Okay.
Okay.
So these are the common indications for what? Usage of LP
Okay.
needles. And I have
Yes,
told you
sir.
the gauges also. What we commonly use is 20. How many
Yellow
of you
needle.
had the experience in doing LP? Have you done LP in your MD period? I mean, what your PG period?
Yes, sir. We have done.
You have done, no? Hmm.
Yes, sir.
Okay, what is the most common needle you will be using commonly? Less
Um,
painful,
um,
less
in,
traumatic.
in in our government setup, we have mostly used the green cannula.
Green cannula, yeah. I understand that government setup you use the IV line cannula to pick up the
Yes,
CSF.
sir.
I understand that. Okay, fine. Otherwise, we use black needle. Okay, black is relatively of moderate size bore. It will not be that much traumatic and that much painful also. Okay. Hmm. Okay. Okay, fine. Go to the next question. Very good. I think there's a CSF report, right? Fine. One of you can try.
Okay, sir.
Sir,
Sir,
Who's
have you
going to
the
tell? Aditya. Aditya.
PLC of 80, which is on higher side with 85% lymphocytes. The protein is mildly elevated. The glucose is within normal limits, sir. Uh,
Rest everything appears to be normal. It is likely uh, either tubercular or viral, sir.
Okay. So they have already given you, hmm,
So,
they have already given you step-by-step analysis of that. So when you do a CSF, first you have to look for the color and appearance of the CSF,
sir.
whether the color is changed. Suppose if there is a red color tinge, it is, you know that whether it may be hemorrhagic or a traumatic tap. Okay.
Yes,
If it is
yes, sir.
yellow color CSF, what you will tell? What does mean being yellow color CSF called?
So xanthochromia.
Xanthochromia indicates what?
Sir, degenerate RBCs or bilirubin, sir.
Very good. It's a degenerated RBCs releasing bilirubin. That means there might be a previous
Bleeding or
bleeding or a post subarachnoid hemorrhage, something would have happened. In that, xanthochromia can happen. What is the second reason why xanthochromia can happen in that?
traumatic tap, sir.
Traumatic will be an acute bleed, right?
Yes, sir.
Xanthochromia can happen because of
SAF,
if there
sir.
is a spinal obstruction or if there is a significant elevation of protein, okay, in
Yes, sir.
chronic meningitis or spinal obstruction, okay, in that
Yes,
time
sir.
the proteins can get clogged or stagnant, they will also appear yellow in color. So for
Yes,
your
sir.
level, when xanthochromia has been asked, one is a sequelae of SAH because of degradation of blood products leading to bilirubin. Two,
Yes,
it may
sir.
be because of stagnation of these protein due to spinal obstruction or because of a chronic meningitis with elevated, very much significantly elevated proteins. In those
Okay, sir.
conditions, it will be like 300s, 400s like that. Protein content will be. Okay.
Okay, sir.
Okay. Fine. So first you have seen the appearance, color you have seen. Now, what is the appearance? They have given clear. What is mean by clear CSF?
So that means it is transparent and without any turbidity, sir.
Very good. If the CSF upon looking is turbid, what does it indicate?
Sir, it can be due to bacterial meningitis, sir.
It is purulent meningitis or a bacterial meningitis. On
Yes,
standing
sir.
for some time, there is a settling of cobweb-like formation. What does it indicate?
It can be due to tubercular meningitis.
Excellent. It can be due to tubercular meningitis. Okay. The second thing what they have given was a biochemical analysis of glucose and protein. Okay. Normally, the glucose should be two-thirds of the serum glucose. So it is always mandatory to send a serum glucose simultaneously with that of CSF glucose. Okay. And if you find CSF glucose to be very low, what are the conditions associated with that?
Sir, bacterial meningitis
Very good.
or the patient himself herself is in hypoglycemia, sir.
In a significant hypoglycemia patient, are you going to do CSF first?
No, sir.
Okay. Mm. Then, yes, Sonam, tell.
Malignancy, rheumatoid
Excellent.
arthritis,
Malignancy, rheumatoid arthritis, and
SLE.
SLE. Okay, but malignancy and rheumatoid arthritis is what expected from a medicine people. From neurologists, it is going to be bacterial meningitis or pyogenic meningitis, tubercular meningitis. This much only. For you people in MD level, you should tell that carcinomatous meningitis or malignancy or some leukemic meningitis can be there sometimes, and rheumatoid arthritis. There are also you can have an increased cell proliferation. Now the cells may consume this glucose. So you have to be knowing about these conditions. Okay. Protein, where do we get protein elevation?
Sir, in bacterial, viral, and tubercular meningitis, sir.
Yeah, it is usually in bacterial, viral, in all the inflammatory conditions, you can get protein elevation.
Yes,
Okay.
sir.
Protein elevation, why is it important? What are the two or three medical conditions in which protein will be elevated but CSF cells will be normal? What is that condition called? What is the terminology used for that?
Sir, albinocytological dissociation.
Very good. That is called albuminocytological dissociation. Where do you get this albuminocytological dissociation?
Sir, it is seen in GBS.
Seen in
GBS,
GBS,
yes,
then
sir. Then, sir, uh, multiple sclerosis, sir.
may be correct multiple sclerosis or any demyelinating disorder, primary demyelinating disorder. Then
Yes, sir. Sir, I will read, sir.
CIDP, have you heard of this? Chronic
Yes,
inflammatory demyelinating polyneuropathy.
yes, sir.
CIDP is the other condition. Okay.
Okay.
Now coming to the cellular count analysis, total count. Tell about the total count. Based on the range of total count, how will you go for diagnosis?
Sir, the total count is raised and it is more of lymphocytic predominant. Therefore, sir, it is more likely to be either viral or tubercular, sir.
Very good. If you have predominant neutrophil count, like from hundreds to thousands or 10,000s, then it is going to be your purulent or a bacterial meningitis. Okay. If you have predominant lymphocyte count, it may be a viral meningitis or a tubercular meningitis. In tubercular meningitis, also in initial period, you may have what do you call
Neutrophilic
neutrophil may be
predominant.
there, then it may turn out into lymphocytes. Or the other ways also it can happen. Initially, it will be lymphocytes. Upon repeated puncturing or tapping, you can have a neutrophil count. So by
Okay,
far
sir.
for MD level, you can tell like lymphocytes for TB as well as viral. Okay.
Okay,
So this
okay, sir.
picture, the number of count is also like meager, moderate only.
Yes, sir.
80 cells, and it is predominantly lymphocytes. Now,
Yes,
this
sir.
80 cells has to be compared with the glucose and protein. Both of them are near normal,
Yes,
right?
sir. Yes, sir.
Near
Yes, sir.
normal. Can it
Yes,
happen
sir.
in TB?
Sir, it can happen in TB, sir, but
TB,
the
mind it, TB is a chronic disease. Okay,
yes,
TB
sir.
is a chronic disease, but it can present acutely also within 5 to 6 days. Kind of presentation it can have, but
Okay,
then
sir.
the pathogenesis of TB and the severity is always like they will have either hypoglycemia or a significantly elevated protein. Here there is no significant hypoglycemia and very mild elevation of protein with moderate amount of cells only like 80 cells and all are lymphocytes. So it's
Yes,
going to
sir.
be aseptic or a viral meningitis. It's going to be viral
Aseptic.
meningitis. The picture that is shown here is a clear CSF with 80 lymphocytes without apparent elevation of proteins and a normal blood glucose. So this
Yes, sir.
indicates a picture of viral meningitis. So now in
Yes,
our
sir.
mind you can frame how will be the bacterial meningitis, how will be the TB meningitis, and how will be the viral or aseptic meningitis. Hope you
Yes,
got
sir.
the point right, all of
Yes, sir.
you.
Yes,
You
sir.
understand?
Yes, sir.
Fine. Okay. Good. Go move on to the next question.
Thank you, sir.
Sarthi is there. This question has to be taken by Sarthi.
Yes, sir. Hello. Yes, sir. I'm Sarthak Kumar Swai. I am post DNB medicine, currently doing senior residency in medicine.
You have completed your residency.
Yes, sir.
Senior resident now.
Yes, sir.
Fine, Sarthi. And then it might be a cakewalk for you. Tell this.
Uh, is mostly re-enhancing lesion, mostly suggestive of
First, you
a
can first you can slowly explain which sequence of MRI are you seeing. Okay, whenever an MRI picture or a CT picture is given, you should say that which cut of
yes, sir.
MRI, whether it is axial, sagittal, or coronal cut. Then which sequence are you seeing? T1, T2, flare, contrast. Which sequence are you seeing? Like that, you have to go slowly. And which part of the body? Brain, axilla, thorax, like that. So you can go step by step.
Sir, is a axial cut, sir, of MRI brain.
Hmm.
It's showing T1 section of MRI.
Huh.
And you can see there is multiple ring enhancing lesion in the brain.
Hmm.
Most probably case of neurocystic cirrhosis,
Hmm.
or it can be other lesion like
How sure are you that this is neurocystic sarcosis?
uh, not sure, sir, but if there is any history, then I can proceed to
Okay, now there
confirm
is
that.
no history. What are the other possibilities that you can consider?
It can be lymphoma also. brain
Then,
lymphoma. Then can be also tuberculosis of brain also, TB,
very good.
tuberculosis. These are the DDs. Right now.
Fine. Anyone else can tell what are the DDs for ring enhancing lesions in brain? Anybody? I want some
Toxoplasma.
new people to answer.
So, Cryptococcus, Toxoplasma, primary CNS lymphomas, neurocystic sarcosis, tuberculomas, brain abscess.
Very good. Do you know the differences of all these?
So usually tuberculomas are larger lesions, can be single or multiple. CNS lymphomas are large uh, single lesions. Toxoplasmas are usually in the basal ganglia region with a perilesional edema, and neurocystic sarcosis has the maximum chances of perilesional edema with symptoms of leading to seizures. And tuberculomas have a high choline peak. So
Mm-hmm.
that's it, sir.
Okay, I think you have read something, but it is not like put up in a concise way. So let me tell you, this is one of the important spotter that is ring enhancing lesions in brain. Okay. So what are the DDs when they ask? You can tell in North. I think here most of them are North people. No, in North it is unless otherwise proved it is going to be neurocystic sarcosis is the first cause because so many patients will come. Second or equal to that of that will be tuberculoma. Okay. Third, depending upon the size and other things, you can see like whether it is a brain abscess or metastasis or demyelination. So these are the five, or a primary lymphoma. So these are the 5 to 6 cases, 5 to 6 causes. But some other chronic infections like toxoplasma, cryptococcus generally do not cause ring enhancing lesion, but they can also. But toxoplasma you should keep in mind. Okay. So first let us see neurocystic sarcosis. Aditya, can you tell what are the stages of neurocystic sarcosis in MRI wise? Or Sarthi also can tell if you know stages of neurocystic sarcosis.
So actually, there are four stages of neurocystic sarcosis.
Very good.
Number one is number two is colloid cystic. Number four is calcified stage, but I can't remember that first was okay.
What man you are telling number two, number four? Who will tell the in between things?
Currently, I'm not able to recollect the things like first one is I know
Vesicular stage.
it's vesicular stage. Yes, sir. Number one
Second
is
one is
vesicular,
colloidal stage.
colloid stage. Third is
Third one is
cystic.
nodulogranular stage or granulonodular stage. And fourth one is
Fourth is calcified.
calcified stage. So these are the 4 stages of neurocystic sarcosis. And in colloidal stage is the only stage you will have intense inflammation and perilesional edema around that. Okay.
Yes.
Hmm? The amount of inflammation will be reduced and the lesion maybe appear cystic or something like that in the granulonodular stage. The cystic, I mean, the quantity of cystic nature will come down. In vesicular stage only, you will see that the lesion will be cystic, and inside the lesion, you can see a small tiny dot in the T2 sequences or flare sequences. What is that dot called as?
Colex.
Scolex. So the presence of Scolex is a telltale sign for diagnosing vesicular stage of neurocystic sarcosis. And finally, the calcified stage is going to give a kind of appearance in a plain CT. What is that appearance called? See, the brain parenchyma appears black. If the calcified NCCs are appearing white here and there, how does it appear like? Just imagine.
Nose, snowstorm.
No storm.
Starry,
Simply you imagine, man. You will be lying down in the bed and
starry
looking up
sky.
the sky. Stars in the sky,
Starry sky.
starry sky pattern.
That is sky.
This is called starry sky pattern. I am giving so much of clue to tell. Somebody is telling snowball or snowstorm appearance. Anyways, fine. Now you will not forget, right? Starry sky appearance. Okay. This is about NCC. And for tuberculosis, see, NCC may be single, NCC may be multiple also, can affect any part of the brain. Here and there it can be present. Okay. And what about tuberculosis?
Tuberculosis, the size of the ring enhancing lesion are larger
Yeah, very
compared
good.
to that of SSC. And there is also some systemic signs associated with tuberculoma
Very
compared to
good.
that of NCC. And
This may be
also
useful for clinical diagnosis, but I am giving you only MRI. You have to tell from MRI.
in MRI, we can only use the size of the ring enhancing lesion. Size
Have you
more
heard of the
than
terminology conglomeration?
yes.
Multiple conglomerate ring enhancing lesions seen like the radiologist giving the report.
Okay, yes, sir. Yes, sir.
Conglomeration means so many lesions are combining together to form a big
Combined.
lesion that will be appearing like some bubbly gubbly appearance here and there because multiple lesions trying to join together. So conglomeration is a characteristic feature of tubercular meningitis. Sorry, tuberculoma or ring enhancing lesion secondary to tuberculosis. Okay. And they can be present in gray white matter junction kind of level. Okay. They may present in gray white matter junction. And most of the time it is infratentorial, but it can be seen both supra as well as infratentorial. And what is the most important peak in MRS? What is meant by MRS?
MR spectroscopy.
Spectroscope, magnetic resonance spectroscopy. In MRS, which peak is helpful for diagnosing TB?
Colin peak.
Choline peak alla baba. Something else. What is lipid lactate peak?
Lac.
It's going to be lipid lactate peak. Okay.
Okay,
Presence of lipid lactate peak is suggestive of.
tuberculosis.
And what peak is going to be helpful in NCC? It's amino acid peak for NCC. Okay. If it is a fungal nodule or fungal abscess, what is going to be helpful? Triholose peak. If you are remembering, it's okay. If you are not remembering, at least note it and keep. Maybe useful for your entrance or you may be useful for your final exam also. There are so much to discuss on this ring enhancing lesion, but okay, we don't have time to discuss everything also. But read up. How will you differentiate between tuberculosis and neurocysticercosis? What are the salient features for each of the thing like that? You can read up. Okay. Finally, when you are seeing multiple lesions, I think the MRI that is shown here, hmm, these are supratentorial lesions. Two lesions on the medial surface of the frontal cortex and one is on the lateral surface. The flare is showing significant perilesional edema.
Lateral also.
Prasequantal.
Prasequantal. Okay, fine. I think with this we can end up this question. Let's move on to the next question. Yeah. Images, I think that's sufficient. Drug table we can go. Yeah. Um, no, here I'll be asking you three questions. Identify the drug. What is the mechanism of action? Where is it used? Give me some important side effects and contraindications. Okay, this is going to be my question, and four of you can answer. First, let me start with the phenytoin. Okay, somebody can answer. Sonam can answer phenytoin. Tell about phenytoin.
Yes, sir. Phenytoin is a sodium channel blocker.
Very good.
In uses it can be it's used in epilepsy,
Mm, it's an anti-seizure medication used to
anti.
control seizures. Mm.
Uh,
Do you know any other use of phenytoin other than epilepsy?
so I can't recall.
Yes, Sarthi, you can tell. You raised hands.
It also can be used as antiarrhythmic also.
Arrhythmia, very good. Then
And,
phenol-
Antidepressant.
Migraine.
Sorry.
Oh, I have not seen or used for
Prophylax.
antidepressant and migraine and all. Sorry. Mexitin and phenytoin is used in one neurological condition. Which is that?
Trigeminal
Okay.
neuralgia.
Nope. So as you said, trigeminal neuralgia, which anti-epileptic medication is used for trigeminal neuralgia?
Carbamazepine.
Oh,
Carbamazepine.
carbamazepine.
Gabapentin,
Carbamazepine,
pregabalin.
ascorbacepine, pregabalin. Very good. Phenytoin and mexitin is used for myotonia in myotonic dystrophy. Okay, you should remember that. Hmm. Tell one or two side effects of phenytoin.
Gum hyperplasia.
Good.
Gingival hyperplasia.
Same
His,
only both are.
yes, sir, yes, sir.
Hmm. Hmm.
Hirsutism.
Ah.
Uh, amenorrhea.
Hmm. What you frequently see in OPD basis, patients on long term as well as acute. Okay, your patient is coming with seizure. Okay, you have loaded the patient with phenytoin, some 1,500 mg of phenytoin you have given. Next day, patient is not able to walk. He is not walking due to dash. Phenytoin is the
Yes,
most common drug that is associated with that syndrome. Syndrome associated with that neurological phenomenon.
Ataxia.
Very good. Who said ataxia? Ataxia is the correct answer. I was expecting for ataxia. It can happen on an acute toxicity also. It can happen in a chronic state also. But other amenorrhea or menstrual irregularity, vitamin D deficiency, osteopenia, all these things can happen. So phenytoin is one of the cheap drug. It's a potent drug also, but you have to give a weightage to these side effects before prescribing, and the condition also you should choose. Okay, fine. Dr. Vivek can answer about mannitol. Where do you use? What is the dosage? Tell me the indications and contraindications for that. When I said Vivek name, Vivek just disappeared. Aditya Mishra, can you tell?
sir. Sir, it is used in raised ICP,
Mm.
either due to traumatic brain injury. Sir, it is also used in acute angle closure glaucoma.
Mm.
Sir, other are the renal indications, sir, in case of enhanced sir, drug overdose to remove the toxin, sir.
Osmotic diuresis.
Yes, sir, osmotic diuresis, sir.
Okay,
Sir,
that and all we are not using now, but that was mentioned previously. I do agree that, but we are in an era that and all we are not using. Okay, fine. How will you dose it?
sir, in our setup, we used to give 100 ml thrice to 4 times a day, sir.
Okay. Otherwise, what is the dose based on body weight?
Sir, 0.25 to 5.5 kg. No, 0.5 to 0.25 to 0.5 gram per kg, sir.
Yeah. You can start from 0.25, 0.5 or go up to 2 gram per kg also. Okay. Hmm. And what test needs to be, what needs to be checked while mannitol is being administered? Once you reach a particular cutoff, you may need to stop the mannitol. What is that?
Sorry, sir, I will read about it, sir.
Okay, that is serum osmolality. When the serum
Okay.
osmolality is more than 360, you should stop mannitol
Okay, sir.
therapy. Okay, what are the side effects and contraindication?
The contraindication is, sir, active intracranial bleed, sir.
Active intracranial bleed, we will be giving no mannitol.
Okay, so sir, in that case, do we prefer glycerol or mannitol?
Glycerol, it takes long time to act. Mannitol
Okay,
is
sir.
relatively faster than glycerol.
Okay, sir. Sir,
You will not give it in complete renal failure, okay?
yes, sir.
Then you
Yes,
will
sir.
not give it in respiratory failure, liver failure, and cardiac failure.
Yes, sir.
The side effects includes dehydration, increased osmolality, precipitation of heart failure by producing volume overload related status and all. Okay, this is what about mannitol.
Yes,
So
sir.
please read about the dosage of mannitol and its side effects.
Okay, sir.
Okay.
Thank you,
Other
sir.
person can tell few points about levodopa, carbidopa, and levipil also. Then we may move on to the next question. 5 minutes only for levipil, not 5 minutes, 3 minutes only for levipil and 3 minutes for LCD. I'll choose a person. Only few are there. Okay, some new fellow. Akash has come. Akash can tell about levodopa, carbidopa. Dr. Akash, would you like to answer?
Sir, levodopa, carbidopa in
Where do you use
the
this drug?
sir, this drug is used in Parkinson's disease.
Very good.
The
What is the
mechanism of
function of
action,
levodopa? What is mean by
uh,
levodopa?
sir, levodopa is a precursor of dopamine, and
Very good.
carbidopa is a peripheral decarboxylase inhibitor for peripheral to control the peripheral utilization of the dopamine,
Very
conversion of
good.
levodopa to dopamine.
Good. Good. So that is fine. Um, so when you are advising levodopa, carbidopa to a patient, which are one or two drugs which will you will avoid? Which vitamin you will avoid? Will you prescribe vitamin B complex medications with these drugs?
No, sir. Vitamin B6 is a we will avoid pyridoxine.
Very good. Why pyridoxine needs to be avoided?
Sir, it has an antidopaminergic action.
Hare Baba, anti-dopaminergic action. Hmm. Pyridoxine acts as a cofactor in which enzyme?
Pyridoxine.
It acts as a cofactor for dopa decarboxylase. No, it enhances peripheral decarboxylation. Though you are
Okay.
giving with carbidopa also, this pyridoxine will be like enhancing the other enzymes, the dopa decarboxylase, and decreases the utility, cerebral utility or availability of this levodopa. That's why you should not prescribe that. Okay. And can you tell some of the side effects of LCD therapy?
Uh,
Or
yes,
have you
sir.
seen patients taking that?
Yes, sir.
Tell me some one or two side effects. Acutely, you can have nausea, vomiting, acute GI disturbance kind of phenomenon can happen. Then,
Oh,
what is a well-known adverse side effect of that? For at least MD level, I'm expecting only one side effect to be told. What is meant by dyskinesia?
uh, sir, drug induced dyskinesias.
These are abnormal movements, right? So that's one of the
Yes.
commonest side effect of levodopa carbidopa. Fine. So read about levodopa carbidopa. That is very important. That's very commonly used also. Okay. Okay. Then levipil. What is levipil? So anybody? I'll ask the moderator only. Moderator can answer if you know. You can help your students.
Levipil is levetiracetam. It's an sp2a uh, inhib- inhibitor.
What is SV2A? What is its function?
So vesicle.
Synaptic vesicle. No. So
Yes, sir.
so all these neurotransmitters are stored or reuptaken in
In the vesicles, and then they're
vesicles.
broken down
So
and released.
hmm. So that is being blocked. It's a broad spectrum antibiotic, anti-epileptic. So,
Yes.
what are the side effects of levetiracetam?
So it has very less side effects. I don't know. I've never seen one.
Okay, tell me the available side effect. Very clever in answering. Yeah, somebody has put in chat box behavioral disturbances. Levetiracetam is known to increase or
Oh,
worsen the
yes, sir.
behavioral disturbances. So it can cause hyperactive nature, tantrums. Okay, there may be rarely drug-induced movement disorders like tremors. Rarely, okay, these can happen. And levetiracetam is relatively safe in dash
Pregnancy. Pregnancy.
pregnancy. Pregnancy. So the drug of choice for epilepsy in pregnancy is 1 dash 2 dash.
Brevactracetam, lamotrigine,
Very good.
levetiracetam.
Okay, very good. Very good. Correct. Fine. Let's move on to the next. Oh my God, he has written some case and all, man. Do we have time for discussion, anyways? No, we can go for the case discussion. I can discuss that case. Like I'll tell you short only. I will not be detailedly discussing. Who is going to present? Somebody is going to present.
Yes. A 52-year-old male presents with a 6-month history of progressive weakness in his arms and legs. He reports difficulty gripping the objects, frequently tripping while walking, and slurred speech for the past 2 months. There is no sensory loss, bowel loss, or bladder involvement, or family history of neurological disorder.
Very good. Next.
History of presenting illness. Onset is insidious, progressive over 6 months. Upper limbs difficulty with tasks like buttoning the shirt and holding utensils. Lower limb weakness causing frequent falls, especially on uneven surfaces. Speech is slurring and nasal in quality, noticed in the fasciculations, noticed in the arms and thighs. No significant pain, numbness, or sensory deficit.
Okay. So could you please analyze this?
So,
Have you ever come across this type of case, Sonam?
yes, sir. This
Okay.
is
So what is the first symptom?
So there is progressive weakness of upper limbs and lower limbs, and according to the history, seems like a distal predominant weakness where he's
Why you
having
are telling it
difficult.
as distal predominant weakness?
So because they have mentioned that he is having difficulty in fine motor skills like unbuttoning, buttoning, and while walking also he's tripping over uneven surfaces.
So tripping over uneven surfaces indicates what?
Foot drop, maybe, probably.
Maybe one is foot drop, excellent. That is
One
the
is
dorsiflexion weakness of the lower limbs. Second one, presence
maybe
of
there is
spasticity, tightness. Spasticity
Spastic.
also can cause or
Mm.
lead to tripping and falling. Okay. So the presence of spasticity is either UMN, where presence of tripping and falling is either because of spasticity or it may be due to the dorsiflexion weakness also. Mm. Now you have told that there is a progressive weakness over 6 months. So any weakness in neurology, you have to classify whether it is a UMN weakness or an
UMN
LMN
or
weakness. LMN weakness. So in this
yes, sir.
patient, what do you feel? Is it UMN weakness or an LMN weakness?
So the
History. See,
weakness,
this is like a short case they have given you. You do not have a detailed history to give a comparison. But with
yes, sir.
available phenomenologies, you can tell whether it is UMN or LMN.
So the weakness is UMN, both UMN and LMN, because there is fasciculations, there is no sensory involvement as well, and there is spasticity as we are thinking. But
Excellent.
LMN in the sense because this it is distal predominant as well.
So spasticity, we are not very clear for the forward because only tripping and falling history is there. So to ask whether human weakness, you should ask
Heaviness
for
of,
history of
yes,
tightness while walking, history of heaviness of limbs while
yes, sir.
either any difficulty in putting the slippers or recurrent episodes of tripping. These are the history that will help you to identify whether spasticity is present or not. Okay, in this patient, whether such kind of history is there. Yeah, there is one subtle clue to tell that there is recurrent episodes of tripping, but we are unaware whether this is a dorsiflexion weakness related tripping or a spasticity related tripping. But the current page shows there is a progressive weakness in addition to that of one more finding.
Fasciculations are there, and there is nasal quality of speech.
Yes, so presence of fasciculation will always indicate that the localization of weakness is LMN. Okay,
Element.
and the
Anterior horn
quality of
cells.
speech also very good, anterior horn cells. So and the quality of speech also matters. So what quality of speech we are getting?
So this nasal quality is seen in bulbar palsy, sir.
Yes, nasal quality is seen in element type of bulbar palsy. Okay, so nasal element type. So overall, from this picture, what we can see is a weakness which is element predominant. Now, you tell me whether only motor affliction is there or sensory affliction is there.
Sir, only motor involvement is there. Sensory, from the history, nothing has been mentioned.
Okay.
So
Now
it
you know
looks,
that that's only motor involvement is there, sensory is not there. The second
yes, sir.
question you have to ask whether there is a bowel bladder involvement is there or not.
Yes, sir. That is not there. So spinal cord
That is
is ruled out.
so that is not given in the history. I think we can ask the moderator. Deva Prabhu, whether there was bowel bladder involvement in this patient. Okay. The moderator says that there is no bowel bladder involvement. So you have a pure motor element type of weakness without any bowel bladder involvement from the history. Okay. One
Yes,
more
sir.
point that you should always remember to ask, especially in case of neurological diseases, any symptoms related to cranial nerve involvement. So, are there any symptoms related to cranial nerve involvement?
So there is slurring of the speech
Which
and nasal
indicates,
quality could
yeah,
be
exactly, could be
hmm,
lower cranial nerve involvement,
lower
right?
cranial nerves. Yes, sir.
Yes, could be lower cranial nerve involvement. But you do not have any visual disturbances, double vision,
Hmm.
diplopia, something like that. Okay. So, can you
Yes, sir.
summarize these findings, history, in 2 lines?
Uh, a 52-year-old male
Hmm.
has come with complaints of predominantly LMN, lower motor neuron weakness, along with the element type of bulbar palsy without involvement of sensory, bowel and bladder and cognition.
Excellent. So, now you should narrow down with your possible differentials. Do you have any differentials now?
So, yes, sir, a motor neuron disease could be one. In LMN, I would like to categorize it into anterior horn cell, muscle, or NMJ, neuromuscular junction. But since it's not been mentioned whether it's a symmetrical or asymmetrical, and I would like to rule out muscle. And coming to
Okay,
neuromuscular,
I'll tell you. This started as fine. It was not mentioned symmetrical or asymmetrical. I'll tell you. This started in the right upper limb. Within 4 to 6 months, it started in left upper limb. Then, fairly symmetrically, it started affecting the lower limbs also. It is progressive weakness of all 4 limbs. It's asymmetric.
yes, sir.
Hmm.
So, I would localize it to anterior horn cell only because in neuromuscular junction, there is fatigability and diurinability and improvement with rest. So there are no such features. So it's a predominantly anterior horn cell involvement. So my first differential would be a motor neuron disease. Second would be cervical myelopathy because there is upper limb weakness, so above C5 and below C3 because there is no respiratory involvement.
Excellent. Then, anything else would you like to consider?
Syringomyelia or
Probably correct.
syringobulbia because there are lower cranial nerve involvement as well, but there is no sensory involvement. So
Syringomyelia and
could
syringobulbia
be
will be having some sensory involvement, no?
yes,
Correct.
sir, yes, sir.
But cannot be ruled out. You need imaging to rule out those things.
Imaging, yes, sir.
Yes, I accept that. Why can't it be myopathy?
So, because that is symmetrically progressive and it is proximal predominant weakness. Our patient has distal predominant and asymmetrical. And
So, do
upper
you
limb
know any types
started,
of distal predominant myopathies?
yes, inclusion body myositis, myotonic dystrophy,
Hmm.
facioscapulohumeral dystrophy.
Very good. You are doing final year medicine, huh?
Yes, sir.
Okay, fine, fine. Good. Then
Mm,
now you are ruled out myopathy also, right? But if at all
yes,
myopathy
sir.
needs to be considered, you know some of the differentials also you have kept. Okay.
Yes, sir.
But within 6 months of illness, only patient has developed profound fasciculations. What does it indicate?
There's atrophy is more predominant than weakness,
Atrophy
probably.
more predominant than weakness. That's why fasciculations has settled in. So again, that favors towards which etiology?
LMN, anterior horn cell.
Ilm and anti-Rahansel. Excellent. I'm really amazed, or like, I'm satisfied with your way of discussing this long case. Okay, fine. So can you put it in a nutshell in 2 lines altogether what we have
Uh,
discussed?
so yes, sir. Lower motor 52-year-old male has come with progressive weakness in 6 months, probably a motor neuron disease of element predominance, a low
Very
motor
good.
neuron disease predominance, along with the element bulbar palsy.
Yes. So you can tell like a 52-year-old man without any comorbidities presented with progressive element pattern of weakness affecting all four limbs along with bulbar dysfunction without any history of bowel bladder, sensory, autonomic or cognitive involvement. So the probable localization I would like to keep: one is anterior horn cell disease, 2 muscle, 3 plus or minus neuromuscular. So I would like to exclude muscle because of so and so. It is not symmetrical, it is asymmetrical. There is earlier onset of fasciculations and atrophy is more predominant than that of weakness in this patient. It is not neuromuscular because there is no history to suggest any diurnal variation. There is no history to suggest fatigability, and age of onset is also slightly different. Okay. So with this in mind, I would like to proceed with anterior horn cell, that is motor neuron disease, as my first DD. Like that, you should tell. Now you can go for examination. I am very happy the way by which you understood and then discussed it. Really good. Okay. Examination.
Uh, Examination, higher mental functions are normal. Cranial nerve dysarthria, brisk jaw jerk, fasciculations of the tongue. Motor system, upper limb has muscle wasting in the thenar and hypothenar. Eminences with reduced grip strength. Lower limbs, bilateral weakness, particularly distal muscle. Tone spasticity in both upper and lower limbs. Power 4 by 5 in proximal and distal muscles of all limbs. Deep tendon reflexes, brisk in all limbs, plantar, extensor, sensory and sensory is intact, cerebellar signs are absent. So, according to examination, it seems like both UMN plus LMN features are present. So,
Okay. What are the human
predom-
findings you get here? You are seeing here.
so there is spasticity, there is extensor plantar, brisk jerks, along with jaw jerk is present.
Okay. Then, so dysarthria we are unclear, no? Nasal
Yes,
quality was
sir.
given in history,
Nice.
but it may be a spastic or a flaccid dysarthria, that we are not sure. So, what are the types of dysarthria, you know?
So, dysarthrias can be hypokinetic, hyperkinetic, ataxic, and same spastic or flaccid dysarthrias. So, like if
And mixed. Okay.
okay, mixed.
So six you remember. Start with spastic, flaccid, hyperkinetic, hypokinetic, ataxic or cerebellar dysarthria. In cerebellar dysarthria, you have scanning dysarthria, staccato
And staccato.
dysarthria, and slurring dysarthria simply. And finally, there can be any kind of mixture, that is mixed dysarthria. This system of classification is called Mayo system of classification. Okay. And you
Oh,
have also mentioned there is brisk jaw jerk. Okay. Jaw jerk is mediated by which nerve?
fifth nerve, sir.
Fifth nerve. What are the causes for brisk jaw jerk?
So, any UMN cause
That means where should be your localization?
for fifth nerve it will be in the pons.
So what can be eliminated when the jaw jerk is brisk? So for that you should know jaw jerk pathway. So what is the afferent and efferent of jaw jerk?
Both are fifth nerves, sir. The center is in the pons.
Pons. So does it come to the spinal cord?
No,
It is not coming to the spinal cord. No. So the pons have a
no.
supranuclear connection from the brain to that of pons, and then through trigeminal nerve it is being mediated. So what one of the differentials that you have kept is getting excluded with this finding.
Syringomyelia and syringobulbar.
Syringomyelia or the upper cervical myelopathy is out because you
Because
have
of
brisk jaw jerk.
spine. Yes, sir.
Did you get the point?
Yes, sir. Spinal nucleus of fifth nerve is not involved.
Yes, mesencephalic nucleus is what that is the center for jaw jerk.
Yes.
And you have got next finding is fasciculations of the tongue.
Yes, sir.
Fine. Motor system. What is the other UMN findings in motor system? You have spasticity and extensor response. And there is
Brisk reflexes.
one more thing that is you forgot to mention was bulk. You should milk. So bulk you have told. Muscle wasting is mentioned. It is there. Muscle wasting is there in thenar and hypothenar eminences. And examination also you should mention about the fasciculations where and all you are seeing. Okay. Since it is a short case, like just for this, what do you call discussion part, I'm not bothered about that. But otherwise, you have to mention bulk, mention about the circumference of the muscles tested, then tone you have to mention, then power, individual systematic power, reflexes, sensory system, cerebellar, gait,
Yes.
finally spine and cranium. Fine. Okay. Next slide. Okay, now we have come to the end of discussion. We'll be closing the session. I think I want to close the session by 6:30. Now you can put up everything together and tell your final diagnosis, Dr. Sanam.
So, my final diagnosis would be a motor neuron disease with both upper motor neuron and lower motor neuron involvement, which is
Sonam,
AMI.
wait.
Yes, sir.
Whenever you wanted to tell a diagnosis, you cannot jump telling motor neuron disease.
Start
You should start
positive.
summarizing the history and MI examination finding in 2 to 3 lines, not like a story. 2 to 3 lines you should tell, and then you tell because of this I am
Yes,
like
sir.
that.
52-year-old male without any comorbidities has come with features of upper motor neuron disease, which involves brisk spasticity, brisk reflexes, extensa plantar, and lower motor neuron features of fasciculation, atrophy, distal predominant weakness, along with dysarthria and absence of sensory, autonomic, cerebellar, and bowel and bladder features. My final provisional diagnosis would be motor neuron disease with both upper motor neuron and lower motor neuron involvement, which could probably be amyotrophic lateral sclerosis.
Very good. Excellent. So you can put it up like presenting a 54-year-old male with progressive weakness, with progressive weakness and dysarthria, without history of bowel bladder, sensory or autonomic function. On examination, he was found to have wasting, atrophy, weakness, along with UMN signs like spasticity, brisk jaw jerks, and extensor plantar. Overall, the patient has both UMN as well as element kind of pure motor weakness without any sensory or bowel bladder involvement. So this would rather localize my etiology to anterior horn cell disease. In view of both LMN and UMN, I will consider motor neuron disease, that is ALS variant of MND will be considered. What investigation would you like to do in this patient?
Sir, MRI of the brain along with cervical spine
Why
screening
do you
to
want
rule,
to why do you want to do that?
to rule out any cervical myelopathy.
Very good. In MRI, are there any signs you can observe from this?
Yes, sir.
You
There'll
should
be
always rule
atrophy.
out. Huh?
Pardon. Demyelination should be ruled out.
No, yeah, no, girl.
Sorry.
It's not that. In MRI, you can see for white matter changes, or you can look for the hyperintensities of the corticospinal tract. There can be mineralization of corticospinal tract also seen. Okay,
Yes.
you just look for that. And blood
Uh,
investigations, what would you like to do?
the normal blood labs, CBCs, and everything. And also, I would like to rule out any paraneoplastic etiologies.
Very good. Which paraneoplastic etiologies are associated with so-called motor neuron disease? I mean the antibodies. If you know, fine. Otherwise, you can read.
No side ones.
But you have to rule out anti-paraneoplastic in view of young age, no? 50 years only. So
Yes,
any
yes,
treatable
definitely.
condition you have to check.
Hmm.
Would you like to check for calcium parathyroid and all? Thyroid, calcium parathyroid?
So yes, sir, for along with other paraneoplastic workup.
Yeah, hyperparathyroidism, hypercalcemia, hyperthyroidism. These are some of the endocrine causes which may be involved in MND.
Yes,
Okay.
sir. Then I would like
And
to,
what other investigation is needed to confirm the diagnosis?
sir, EMG NCS has to be done.
Very good. In EMG and NCS, what you will see?
Fasciculations and fibrillations can be made out on,
EMG, fine. Very good. You can
and
see denervation
and
changes, right? Hmm.
yes, sir. And we can the for the criteria of ALS, we need uh, genioglossus, cervical, thoracolumbar involvement that can be made out on an NCS.
Excellent. Very good. Since you have answered this much, tell me what is the current criteria and what is the previous criteria used?
I don't know the previous one, but the current one is out of four, we need three to call it ALS.
I'm asking the name of the criteria. Okay, you can read out. The
Yes, sir.
previous criteria name is L Escorial criteria. ELESCORIAL, L Escorial criteria. The
Hmm.
current criteria is Gold Coast criteria. So whenever you have time, you can read up through those. Okay.
Okay, sir.
Do you have any medicines approved or like used for this?
So we have only riluzole, but that just prolongs the lifespan by 3 to 4 years. No definitive treatment is available.
3 to 4 years. Oh my God. That is your new study finding, I think. That's okay. It improves lifespan, but not up to 3 to 4 years and all, like maybe some 18 months or 1.5 years, like that. Okay.
Okay, sir.
Otherwise, you presented this case very well. This may be a long case for you in MD. I mean, the final year exams. Where are you doing your PG?
Sir, in Mumbai, sir, Kokilaben Hospital.
Oh, nice. Fine. Good.
Thank you.
I think we can call it a day. All of you have participated very well. The discussion was very. I think the discussion would have been useful for you guys. Okay.